the spirit of recognising the contribution and effort of people locally here in Canterbury, I will very shortly call on Nigel Millar, Dr. Nigel Millar, who is the Chief Medical Officer here at Canterbury District Health Board. Now, Nigel wears many hats, and among them, obviously, is a Chief Medical Officer, but he is also the clinical lead for the Commission's Atlas of Health Variation program, and has been actively involved in Interi as well since its inception, and has been a fellow since 2008. Some of you will not know, but Nigel really was at the heart of how this opioid work and this collaborative program has come about. And I can't remember exactly the year, but Nigel and Mary Seddon and I think others were sitting at a health roundtable meeting, and this idea spawned of a collaborative that they might start with an adverse drug event trigger tool. And so Canterbury, Capital and Coast and counties started this piece of work with some phenomenal results. The opioid work has been driven out of that, and in fact that very collaborative ended up being published in the New Zealand Medical Journal. So Nigel will talk a little bit more about that. But Nigel provides advice to the board and management at Canterbury, is known for some of his inspirational leadership and very forthrightness as he speaks. He specialises in geriatric and general medicine and graduated from the University of Newcastle upon Tyne and then immigrated to New Zealand in '92. Nigel's particular interests, I know, are in the effective and efficient provision of healthcare and support for older people and health informatics. So I'd like to call upon Nigel to give us a few words and officially open our wee forum here. Thanks, Nigel.
Thank you very much. I hope you can hear me. I hate standing behind these things, so you get the whole me. Why am I here? Well, I'm first here to welcome you to Canterbury. One of our best days. It will be shortly. It's great. I'm really here, I suppose, because I'm sick and tired. I've been sick and tired of my patients, as a geriatrician, being harmed in the courses of their healthcare. I'm utterly fed up with it, and we have to do something. Because those are the people I see, particularly. I do general medicine, and they're all old people, and I do aged care. And it's terrible what happens and it's nobody's fault. It's just we collectively have to find a way out of it, and we can find a way out of it. There are ways out of it, because there are people, and in the end, when you're designing health systems, you realise when you work in aged care, you're designing it for yourself. And my hair's gone grey, and I'll need these health services one day. If I'm lucky, I'll be old. So I've got a vested personal interest in getting this right, and as we all know, you all know opiates are a big deal. So let me find a clicker here and go through a few thoughts about what we could be doing. I've pinched them all, because this is what collaborative is about. You steal ideas, and you're willingly given them, and you use them, and you work together. The collaborative we put together around the trigger tool was just spontaneous. We did it. We said, well, we're not going to ask anyone, we'll just do it. It's the right thing to do. And the collective power you have in this room, you've got the ability to do almost anything. If you choose to do it, and you choose not to be limited in your aspirations. So, I'll just talk a little bit of what I see happening around patient safety and where we sometimes go wrong to help you get framed up for the morning. You may have seen this book. You may not have. If you want to get inside safety, it's probably the one to read. There's a little image on the front there, which I'm going to explore. So we see this concept, Swiss cheese. You've all done the Swiss cheese. It's all a bit passé, isn't it? Well, it's actually only part of a model. Okay? More slices, less holes, the stuff. There's more to it than that. So you've got the hazard and the bad bit at the end and the slices in the middle, so let's not line up the holes. All those, all that sort of stuff. That's far too simplistic. You need to get deeper into this. We tend to have something go badly wrong, and we do this thing. We find the unsafe acts. So we had a tragedy you probably saw in the paper recently. A lady was known to be allergic to trimethoprim, and in the course of her health care, somebody said, oh, urine infection, let's give her some trimethoprim. You can see that happening. It's a benign drug, wouldn't cause any harm, would it? It's not like penicillin that people are allergic to. It's funny how things stick in our head. And what's in that is cognitive bias. We think things because we're driven to think them, not because we think. Well, again, we think things because we're driven to think them, because we think. The most obvious cognitive bias you'll be familiar with is sunk cost. We've invested so much in this, we can't stop now. Okay? That's a very common mistake people make. I mean, we had the, we had obstetric registrar was doing a mid-cavity rotational forceps, and he was thinking all the time, oh, I've got this far, it's okay, got this far, it's okay, and that's a continuation bias or a confirmation bias. So these cognitive biases, if you want to read something about safety, read about cognitive bias. You will find suddenly you will be disconcerted about the things you think. So we look for the unsafe act and we try and fix it, and that is very much focusing on what people do. What people do is really important. And those of you from anyone here from acute pain services? Okay, message for you. It's what they do when you're not there that matters. So invest in that. Excellence in practice in acute pain services will not do much for the patients because you're never there all the time. So it's what happens when you're not there. It's really important. So the unsafe act in itself tells you something, tells you about the barriers, tells you about the processes, but it doesn't tell you what really matters is what's beneath that. Oops. It got stuck somewhere. Am I pressing the wrong button maybe? Oh, yes, I am. There you are. There are two buttons here. One below the other, and you're allowed to press the wrong one. Get the message? There's no barrier there, okay? So below this, we've got the local workplace factors, the things that happen around the place, the way we do things around here, the normal the noise, all those sorts of things that go on. But behind that, we've got something really, really important, the organizational factors. This is what really drives all of this, okay? You can't fix all this yourselves, but you need to understand it, to understand when you've got the opportunity to get inside these organizational factors. So I'll talk about some aspects of this. So hazards are everywhere. We know these things. All drugs have an LD50, don't they? There's not much use if they don't, because they probably don't do anything, okay? Gravity is everywhere, so you can fall over anywhere. You're not protected from falls by going to a rest home. In fact, the chances are you're probably more likely to fall. We've got to think outside of our preconceptions. Bacteria are everywhere. We're covered in billions of them. They're not all bad, but they're everywhere, so they're on your hands now. Who washed their hands before they had the cup of coffee? I won't ask. Cutting people open is inherently an unsafe practice. So we have all these risks, things we do. But the barrier is unreliable. We employ human beings, a great thing we do. We employ people, but they are human. So they will make mistakes. I make mistakes regularly. So on the ward round, I say to the RMOs and the house surgeon, I say, you've got a job today. Your job is to pick up my 3 deliberate mistakes. Okay? So I'm going to make 3 deliberate mistakes. You don't get them, you don't get a good report. I get a bit, just to make them feel slightly anxious for a moment. And so we set off, and you know what happens? What I have to do? Practice normally. And they find the non-deliberate mistakes every time. Oh, you sure about that? They say with glee. Do you really want to give warfarin? When the person's last minute, oh, good, well spotted, I say. Okay? We do it all the time. We're all human. Systems are terrible. I could go on like this forever, so I won't, because I haven't got forever. I've got a limited amount of time, so I won't go on forever, but systems are terrible, and our health system, very poor processes. Health is complicated. There are many steps involved and many people. And we've got this continuing harm. I said, I'm sick and tired of this. We've got to start looking further, though, than taking away the danger, strengthening the barriers, or blaming the people and saying they're the problem, because we're going to employ people forever. And I wouldn't trust a computer to do it yet, and probably not for a long, long time. Going below this is where we need to start looking. So what's going on? We're in a rush. We want to get things done quickly. I walk down the ward, and someone stops me and says, Mrs. So-and-so's got constipation. I can fix that, so I'll do that. Mrs. So-and-so's got some pain, so I can fix that. Mrs. So-and-so's got a urine infection. You see what's going to happen? So I'm stopped 5 times down the corridor by people who want to get stuff done or rush things. We don't think how other people are thinking. We don't treat each other with professional respect. Missed hand hygiene. The Canterbury DHB has perfect hand hygiene. Where? Anyone know where it is? Theatre. Perfect culture. I'm the nurse. I say to the surgeon, you're not sterile, everything stops. How can we do that in the theatre and not anywhere else? Because we choose to do it that way. We haven't yet worked out how to change our thoughts. Rushed handovers, quick hand rush, we'll just tell you I'm off, It'll be okay. You know what to do. The concept that everyone's going to fall, it's inevitable, you can't do anything about it. We had a big row at our clinical board a few years ago when I said, zero harm from falls, and they said it's impossible. I said, okay, tell me how many broken hips you want, we'll organize it. Okay, let's think about this. And then there's the thing about the environment, interruptions, like I said, going in the corridor, getting stopped, people ringing you up, asking you questions when you're doing something. We have warning overload. People keep warning us about things, or the computer starts telling us all the time, you can't do that, it's dangerous, can't do that, it's dangerous, you can't prescribe. One system I worked with a few years ago, you can't prescribe ACE inhibitors and furosemide together because it's dangerous. Great, everyone's on it, what's the problem there? So, and inadequate information, we don't know what's going on. Our IT systems are poor at the moment. Bullying, if you don't do it quickly, you're in trouble, and fatigue. We don't manage our own fatigue. Never mind the organization managing fatigue, we don't manage our own fatigue. We're tough, we can keep going. But below that, something more important is the organizational stuff, the stuff that I'm responsible for and feel bad about. Financial focus. I have the good fortune to work with the District Health Board and a chief executive who, when we start about finances, I can say, hang on a minute, the only way to fix the finances is to fix the care. Manage the business, not the money. Okay? But you may have noticed that's not always as good as that. We tend to push safety back to the front and say that's, the people will organize that, they're good at that, they're professionals, they're we can rely on them. We have this idea of professional excellence will see us through. So as a doctor, I learned at medical school, the way to be safe was to work harder, see more patients myself, double-check everything myself, and if I was personally excellent, everything would be fine. Which, of course, doesn't work, because it's about team. A detachment can happen at the organizational end. We had a wonderful moment recently where we brought the father of a child who died, a child who was severely brain injured at birth, to the board. That was great because we broke the detachment. And this wonderful man stood at the board and he looked them all in the eye. He said, I understand what's happened. I understand that all these great people did work, and the doctor who was involved in this, we really feel for him. He looked the board members in the eye one by one. He said, but I'm never going to forgive you. Well, it was a brilliant thing because it broke the detachment. And a culture in organizations where credit is taken at the top and blame is pushed down. Okay, you might have experienced that. These are the things we have to work on. But all of us must do that, because credit, for example, if something is achieved, there's no limit to what you can achieve if you don't mind somebody else getting the credit. And credit is infinitely divisible. You can hand it out to as many people as you like. The minute you take the slightest part for yourself, then it diminishes. So, what are we going to do? We have to work for a culture of safety. We have to get these people out of the organizational end into safety rounds, going around talking to people at the front line. So you could invite your chief executive to your opiate program, come and see what we're doing and talk to some of the patients and the staff. Send them an invite. Be an anarchist. Watch them try and turn you down because you send it again and again. We'd love you to come and see this. You can do this stuff. Who's going to sack you for inviting the chief executive for a cup of tea? Care is the business. You've got to keep saying that. The way to manage the money is to manage the care. If we stop poisoning people with opiates, we'd have money to employ the people we need to look after them. Okay? So in fact, a leadership model. Adaptive leadership in an organization is where the role of the leader is to identify and clarify the problem. The solutions come from those people who know what they're doing, and they're accepted. So we as the leaders have to allow you to take risks to do things we're not quite sure if that's the right thing, but you know better. And this concept of reversing the credit cycle. We need to work on workplace design. We need IT systems that give you more time with patients, not less. So if you're developing a system around opiates, careful, is it going to reduce the time with the patient? And if not, how can we fix that? Alarms need to be ergonomic, need to be thought through. So what alarms do you need on your system? When we eventually get to the electronic medication, what alarms do we need around opiates? It's no good saying dangerous is an opiate every time we prescribe one, because that's not going to help. Because people say, do you think I'm stupid? I've read about this stuff. So you've got to find out what alarms you're going to have around it. How are you going to do that? a compassion process. We've got to work really hard to think about the people we work with, compassion for our colleagues as well as our patients. And the fatigue management, including personal fatigue management. We need to give time for the clinical process. Adopt the theatre hand hygiene model. Why can't I just say to somebody, if I'm the medical student, why haven't you washed your hands, you're not sterile? Hand them the gel. Hand over time and some ambitious thoughts. Zero harm from opiates. We need to get to a point where all our hazards are known and are documented and well known to us and we're familiar with them, so we can anticipate the drug adverse event. When it's going to happen, we know we will get some, but we're ready for it. We can pick it up at an early point. Intervention before people fall. We're going to wipe bacteria off our map. And we can cut people open in a way that's safer than it is now. And we see the humanity in our people. So when something goes wrong, our first thing is to make sure the patient's okay and the family are okay, and then the staff are okay. Because they are humans. You burn them once with an error, and they'll then start acting in a way to avoid the error, which will cause other problems. Systems that are reliable. We need to simplify this stuff and make it far too complicated. And less steps involved and less people. Zero harm has to be our aspiration. We have to be brave enough to say it. It might not be today, it might not be tomorrow, it might not be before I end up as a patient, but I damn well hope it is. But we have to say it. Be brave enough to say it. And look deeper, like I've talked about here. Looking for better systems, stronger barriers. No more blame, and a leadership culture where, in fact, you are now the leaders for the country in opiate safety. So you can take credit for that, in the sense of not credit, you can take responsibility for that, but you can front up in your organizations and be slightly irritative until you think things have been done properly. So I'm so pleased you're here. Thank you for taking the time to come to Christchurch. I hope you have a good day. Thank you very much.